Hi, my name is Allison, and this is my analysis of existing epidemiology data. So, to give a basic overview of my introduction and statement of the problem, I wanted to examine obesity and associated risks in pregnancy. So, the CDC defines obesity as weight is higher than what is considered as a healthy weight for a given height, as described as overweight or obese. And they break it further down using the body mass index that I've included and then given a side by side of comparisons for BMIs, starting BMI expected weight gain for each classification. And those are broken down by ranges of underweight, normal weight, overweight, and obese. And there's even another subcategory that's defined as severely obese, but predominantly the studies I found discussed underweight, normal, overweight, and obese. And why this is a problem for primary care providers or any provider that's dealing with a woman that could potentially become pregnant is the prevalence of obesity in a woman of childbearing age is estimated at 32%. So if you're dealing with a population that could potentially become pregnant in your practice, you have to look at the risks associated with that obesity or overweight and counsel patients even before they're considering getting pregnant and just letting them know what those risks could be. So, the purpose for me analyzing the epidemiology data for obesity in pregnancy and the associated risks is I have been doing my scholarly project on reproductive and contraceptive needs of women in rural areas. And this was an easy transition for me to make because even if you're not going to be dealing with pregnancy in your practice, you're probably still going to be seeing women of reproductive age. So you may ask yourself, why do I care about pregnancy or associated risks if that's not going to be part of my practice? And my answer to you is the prevalence of obesity in the United States is high. It's not going anywhere. It's a problem we all need to address. That, coupled with having women of reproductive age in your practice, gives you reason to educate yourself on risks and educating your patients that may be considering becoming pregnant about these risks. So, the risk of or prevalence of obesity in women of childbearing age is estimated at 32% according to the National Health and Nutrition Examination Survey. So 32% of women of childbearing age are considered overweight or obese. That's a pretty significant number and percent of your patients that are at risk for developing complications or adverse outcomes during pregnancy. So not only do you have that high rate or incident, but also the CDC reported in 2018 that approximately 48% of women who are pregnant gain more than the recommended amount of weight during pregnancy. This doesn't state that it's just overweight or obese women. This is 48% of all pregnancies are gaining more than the recommended amount. So those that are on the line before pregnancy could find themselves falling in that category postpartum as well. So this is significant numbers for your practice. So again, you may say, well, why does this matter to me? Well, you need to educate your patients about the risks and encourage women who are of childbearing age or considering future pregnancies that it's better to fall within or work towards a normal BMI reading so they can avoid these risks that are known or associated with obesity and pregnancy. So, just another statistic to reiterate why providers should be interested in women of childbearing age and the obesity rates. The 2018 CDC Morbidity and Mortality Weekly Report analyzing data from 38 states over a 5-year period showed approximately a 2% increase in increased pre-pregnancy BMIs, indicating the population at risk has not decreased and instead has increased and more education is necessary. Specifically, I looked at the latest statistics for Kansas, and instead of trending upward in the number of normal weight pregnancies, we've actually had a 2.7% decrease in normal weight pregnancies. Now, this report did not specify whether it was an increase in BMIs or increase in unhealthy underweight BMIs, but statistically, there's more probability than it's women of overweight BMIs. This guide provides a great picture of what it was like trying to find current literature that was original source within the last 5 years. That would be the skinny little arm there. And then cohort retrospective studies were the big strong guy there. It was very difficult to find any data that wasn't a systematic review, literature review, or meta-analysis of existing literature. So none of the studies that I did found were disputing the fact that increased BMI and weight were consistently causing adverse outcomes. So what I focused on was the relationship between the BMI and the incidence of adverse outcomes and how they related and what the strength of the relationship were. Because I was just not able to find any literature within the last 5 years that weren't these systematic or meta-analysis reviews. So none of that data was really disputed. In fact, it was all just stated as fact, and a lot of the data supported that those findings were in fact true, as I share later on in my comparison of the two studies that I chose to review. So, although it was difficult to find current research articles that were quantitative for adverse outcomes in pregnancy related to obesity, all of the retrospective studies and ACOG practice bulletins agreed, and nobody disputed that women who are obese are at increased risk for pregnancy loss. They have a higher rate of miscarriage, birth defects, especially neural tube defects, difficult to obtain quality testing like ultrasounds during obese pregnancies, macrosomia, which is the child is large for gestational age, preterm birth, stillbirth, hypertension, diabetes related to pregnancy, increased risk for diabetes postpartum, after pregnancy, preeclampsia, increased risk for infection post-operatively, vaginally and cesarean section, increased risk for cesarean section. None of these studies, including ones cited by the articles or even when reviewing the meta-analyses and reviews, systematic reviews, disputed the fact that these were all associated risks. Just finding that literature that was published within the last 5 years proved difficult because there were predominantly systematic reviews, meta-analyses, or these cohort retrospective studies of these large numbers of pregnancies. Okay, so for the two studies that I chose, they were both cohort retrospective studies. One was in the US, one in the Scotland, and they had similar numbers. For the US, there was 112,309 deliveries, and for the Scottish, 124,280 deliveries that met criteria. For the US, the data was pulled from 12 hospitals over a 6-year period, and that was part of the consortium on safe labor. And for the Scottish study, it was over every delivery at a hospital over the 7-year period, and they use the morbidity records 2 data, and they have like a 98% completion rate. Relative risks were figured using modified multivariable Poisson regressions and 95% confidence intervals for the US study. And 41% of the women meeting criteria for the study were overweight or obese prior to pregnancy. And for the Scottish, they used a multivariable analysis, evaluated risks and related costs in normal weight and compared with women who are overweight or obese or severely obese. So even though one was looking at controlling for pre-existing conditions in the U.S. study, and the Scotland cohort retrospective study was looking at the costs associated with obesity and overweight and adverse outcomes, they both had the similar variables and risks that they were assessing for, and they both had the same data criteria, including BMIs evaluated prior to pregnancy or within the first 16 weeks of pregnancy for the Scottish study, and 14 for the US. So for this US study, it was the first of its type, at least in the United States, to comprehensively exclude maternal pre-existing chronic illnesses for women who were normal weight, obese, or overweight. So they're controlling for pre-existing or chronic illnesses in these overweight and obese women to see if this dispels or creates a difference in the adverse outcomes. So they excluded any women with HIV, um, gastrointestinal, renal, heart, or thyroid disease. The Scottish study looked at some of the same adverse outcomes but didn't control for pre-existing or chronic illnesses. So they are looking at adverse outcomes associated with increased risk for women who are overweight or obese and their cost compared to women who are a normal BMI. So even though these studies looked at two different problems associated with obesity, they both studied and looked at the same variables, including gestational diabetes, hypertension, placenta previa, C-section rates, increased infection rates, induction rates, abruption, third and fourth degree lacerations, fever, wound complications, hysterectomy, and elongated stays related to the obesity, and then the costs associated with that with the Scotland study. I'm not going to read this one for you word for word. You can look at my side-by-side comparison and see that they were almost identical assessments of these studies because they were both assessing the same risks associated with obesity and overweight in pregnancy, even though they were looking at different aspects of the risks. The U.S. tried to control for pre-existing conditions, but you aren't able to prove temporal relationship. The strength of the association in the U.S. For obese women are 4 times as likely to have hypertension and 5 times as likely to have diabetes. And the strength for the Scottish was a strong gradient of evidence linking increased BMI with increased adverse outcomes. For the dose-response relationship, it was clearly stated in the Scottish study, less clearly stated, but still found for hypertension, diabetes, and increased delivery via C-section for the U.S. The exact same findings for replication. Yes, you could apply these to similar studies. The biological plausibility is consistent for both with known risks associated with pregnancy. The U.S. sought to find the alternative outcomes or explanations for these outcomes and were unable to. Cessation of exposure, yes, for both. If you decrease BMI and weight, then you're going to have less indication or less outcome of adverse outcomes. And it was consistent with other studies done looking at obesity and BMI and the adverse outcomes, and neither one are you able to find specificity of the association. So, in conclusion, I thought I would share this nice visual I found showing you known associated risks of obesity and pregnancy, and a reminder that primary care providers should discuss family planning with women of childbearing age. Overweight and obese women of childbearing age should be counseled on the risks of obesity and overweight in pregnancy. And overweight and obese women should be counseled on preconception goals for weight loss or achieving a BMI within the normal range prior to pregnancy.